So, now continue with the ulcer. How we will palpate the ulcer? We will palpate the ulcer by through edges, base, mobility, bleeding, and surrounding area. The edge induration hardness of the edge is very characteristic of squamous cell carcinoma. It is said to be host defense mechanism. Tenderness of the edge is characteristic of infected ulcers and arterial ulcers. It is the area on which ulcer rests. Marked induration at the base is diagnostic of squamous cell carcinoma. Induration, maximum induration, squamous cell carcinoma, minimum induration, malignant melanoma, and Brownian induration, abscess, cyanotic induration, chronic venous congestion, as in varicose ulcer. The, the edge, base, and the surrounding area should be examined for induration. Mobility, gentle attempt is made to remove the ulcer to know its fixity to the underlying tissue. Malignant ulcers are usually fixed, benign, and ulcers are not. Malignant ulcer is friable like cauliflower. On gentle palpation, it bleeds. Granulation tissue, as in healing ulcer, also causes bleeding. Surrounding area thickening and induration is found in squamous cell carcinoma. Tenderness and pitting on pressure indicates spreading inflammation surrounding the ulcer. Relevant clinical examination, regional lymph nodes tender and enlarged, and acute secondary infection. नॉन टेंडर एंड enlarged chronic infection के अंदर हमें देखने को मिलती है. नॉन टेंडर एंड हार्ड स्क्वेमस सेल कार्सिनोमा के अंदर हमें देखने को मिलती है. एंड नॉन टेंडर लार्ज फॉर्म मल्टीपल इज सीन इन मैलिग्नेंट मेलेनोमा. Management investigations, complete blood picture is HB percentage will be seen, its total leukocyte count and ESR and PS, urine and the blood examination to rule out diabetes, chest x-ray PA view to rule out pulmonary tuberculosis, pus for culture sensitivity, lower limb angiography in cases of arterial disease, X-ray of the part to see for osteomyelitis, biopsy non-healing malignant ulcers. Treatment, address cause, correct deficiencies, control pain infection, debridement dressing and closure defect. So treatment of the ulcer should be treatment of spreading the ulcer, treatment of healing the ulcer, treatment of chronic ulcer, treatment of underlying disease. Treatment of spreading ulcer, pus culture sensitivity report, appropriate antibiotic solution to treat the slog, H2O2 and eosol Edinburgh University solution. Excessive granulation tissue excision and application of copper sulfate or silver nitrate, and repeated dressing. Regular dressings are done for few days. Antiseptic creams like liquid iodine, zinc oxide, and silver sulfadiazine. Culture swab is taken to the rule Streptococcus hemolyticus. Ulcer is small, healed by itself. Large free split skin graft applied. These treatment of chronic ulcer, these do not respond to conventional methods of treatment. The following are tried: infrared radiation, short wave therapy, ultraviolet rays decrease the size of the ulcer. Amnion helps epithelialization. Chronic helps in granulation tissues. These ulcers ultimately may require skin grafting. Now let's come to the sinus. What is the definition of sinus? The blind tract lined by a granulation tissue leading from epithelial surface down into the tissues. Blind tract lined by granulation tissue leading from epithelial surface down into the tissues, and in Latin, hollow or a bay. We can uh, we can easily see the diagram of sinus here. Cause, there it is has two causes: congenital and acquired. Preauricular sinus and acquired. TB sinus, pilodial sinus, medium mental sinus, and actinomyosis. Fistula. Now let's talk about fistula. Abnormal communication between lumen of one viscous and lumen of another internal fistula, or between the lumen of one hollow viscous to the external fistula between any two vessels. Latin, flute or a pipe or a tube. congenital or acquired. Branchial fistula, tracheoesophageal, umbilical, congenital AV fistula, and thyroglossal fistula acquired. Traumatic, inflammatory, malignancy, and iatrogenic. Acquired, traumatic. Following surgery, example intestinal fistulas, fecal biliary pancreatic, following instrumental delivery, difficult labor. Example vesicovagal, rectovaginal, and ureterofacial fistula. Inflammation, intestinal actinomyosis, TB, malignancy, when growth one organ penetrates into the nearby organ. Example rectovesical fistula in carcinoma rectum. Iatrogenic seminofistula, AVF for hemodialysis. ECK fistula to treat esophageal varices and portal fistula external internal. Orocutaneous, enterocutaneous, epidicular, and thyroglossal and brachial. Internal tracheoesophageal, colovesical, rectovesical, and AVF and cholecystodernal. This is the figure, and we can easily see how it is. Um, Figure A is sinus and figure B is fistula. Both usually arise from preceding abscess. This shows that a sinus is a blind tract in the case of pilonidal sinus with hairs. This shows that a fistula is a tract connecting two line surfaces in the case of colocutaneous fistula. Causes for persistence of sinus or fistula: presence of a foreign body, that is suture material, presence of necrotic tissue underneath the sequestrum, insufficient or non-dependent drainage. For example, TB sinus. And then distal obstruction, for example fecal or biliary fistula. uh, Persistent drainage like urine, feces, CSF, and lack of rest. Epithelialization or endothelialization of the tract. Example malignancy, dense fibrosis, irradiation, malnutrition. Specific causes. Example TB, actinomyosis, ischemia, drugs. Example steroids, interference by patient. Clinical features usually asymptomatic, but when infected manifest as recurrent persistent discharge. Pain and constitutional symptoms if with deep seated origin. Clinical examination. Inspection. Location usually gives diagnosis in the most of the cases. Sinus, preauricular root of the hallux of the ear, median mental symphysis minty, TB neck, and fistula, branchial, stenomastoid, anterior border, parotid region, thyroglossal midline of neck below hyoid. These are the images which show that we have discussed above. Number usually single but multiple seen in HIV patients or actinomyosis opening. A sprouting with granulation tissue foreign body, flushing with skin TB, surrounding area erythematous inflammatory bluish TB, excoriated fecal pigmented chronic sinus fistulae. Discharge: white, thin, caseous, cheesy like TB sinus facial fistula, yellow sulfur granules, actinomyces, browning granules, osteomyelitis. Yellow purulent staph infections, thin mucus like brachial fistula. Saliva, parotid fistula. Palpation, temperature and tenderness. Discharge after application of pressure over the surrounding area. Induration present in chronic fistula sinus as in actinomyces. TB sinus induration absent. Fixity, palpation at deeper plane. Lymph node TB, thickening of bone underneath ohm. Investigations would be C, BP, HB, TLC, DLC, and ESR. Discharge: For CS, AFP, cytology, gram, and staining. X-ray of the part to rule out home foreign body. X-ray, KUB, and USG abdomen in cases of lumbar fistula to rule out staghorn calculi. MRI biopsy from edge of sinus. CT sinusogram. Fistulography and sinusography for knowing the exact extent origin of sinus fistula. Water soluble or ultrafluid lipodial iodine dye is used. Lipodial iodine is poppy seed oil containing 40% iodine. Treatment basic principles: antibiotics, educate rest, educate excision, and educate drainage would help this to treat. After the excision or the surgery, specimen should be sent for HPE. Treatment of the cause. Example for ATT and TB sinus. Removal of any foreign body. Sequestrectomy of OM. These are the pictures showing the surgery. Tubercular sinus of neck. Causative organism, mostly it is tuberculosis but also M. morbidus. Site and mode of infection: lymph nodes in anterior triangle from nostrils, lymph nodes in posterior triangle from adenoids, supraclavicular nodes from apex of the lung. Clinical stages: Stage 1, lymphadenitis, discrete nodes, non tender, firm, hard, mobile. Stage 2, that is, we can see that matting, firm, non tender, move together on mass due to periadenitis. Stage 3, cold abscess, deep to deep fascia. Stage 4, collar and abscess rupture through deep fascia under the skin, cross fluctuant adherent of the skin. Stage 5, sinus formation. Stage of cold abscess due to cessating necrosis, non-tender cystic fluctuant swelling not adherent to overlying skin. Sternocleidomastoid mastoid contraction test present deep to deep fascia. Trans-elimination negative. Zigzag aspiration by wide bore needle in area to avoid a persistent sinus. Installation of 1 gram streptomycin INH in solution with closure of a wound without placing a drain. ATT note: IND not drawn persistent TB sinus. Stage of collar and abscess. Cold abscess ruptures through deep fascia forming an fluctuant adherent to skin treated like a cold abscess. Collar and stud abscess. Stages of sinus. Collar stud abscess burst out leading to a persistent discharging sinus, can be multiple wide opening undermined edges, non-mobile and bluish discoloration around the edges. It is non-induration. Investigations can be done like hematocrit, ESR, S-albumin, S-globulin, FANC of lymph nodes and smear of AFB and CS, open node biopsy of lymph nodes, edge biopsy of sinus granuloma, Mantox test can be done, chest X-ray, sputum of AFB. Sometimes USG neck to detect cold abscess can be done. Hypoechoic lesions with internal echoes, SO debris within, guided aspiration of cold abscess. Treatment: ATT excision of sinus tract with excision of diseased lymph node. Fistula in ano, chronic abnormal communication usually lined to some degree by granulation tissue which runs towards from anorectal lumen to skin of perineum or the buttocks external opening. Arteriopathogenesis, cryptoglandular, that is in 90% of the cases is found, and non-cryptoglandular, that is 10% cases are found. TB, diabetes mellitus, Crohn's disease, carcinoma rectum, trauma, and lymphogranuloma venereum, radiotherapy, immunocompromised patients.